The third and final, my third and final presentation today, and this is also the most difficult one because it's on a condition that is most often overlooked prenatally, and it's quite difficult to have enough clips to illustrate a picture, to illustrate this lecture, but I did my best, and I will try to show you some examples of these abnormalities that are very important to detect prenatally. Just a quick reminder that in the normal heart, we have usually 4 pulmonary veins, 2 each from each lung, the superior and inferior, that connect with the posterior part of the heart in the left atrium. And these veins are usually very small, from 1 millimeters in the first trimester of pregnancy to almost 3 millimeters at term, because they receive a little bit of blood flow from 30% of the cardiac output at 20 weeks to 20% during the third trimester. And that's why they are very small. There is not a unique pattern of pulmonary veins in the human being. In almost 50% of the cases, we have 4 pulmonary veins, 2 from each lung. But in up to 20% of the cases, we have only 3 because there is a wide and short connection of the pulmonary veins coming from the right lung. In 11% of the cases, there is a narrow but longer connection of the both pulmonary veins, and in up to 20% of the cases, there are additional pulmonary veins coming from the left lung. So only 50% of the people inside this room only have 4 pulmonary veins. Many people have 3 pulmonary veins, and many have more than 4 pulmonary veins. From the prenatal ultrasound, under very favorable condition, we may see sweeping slightly the transducer, the 4 pulmonary veins in V mode, but they are much better seen using color Doppler, to detect slow motion with low PRF, and to see the 4 pulmonary veins entering in the left atrium. When we explore these veins, these vessels with pulse Doppler, we see usually this antegrade flow during the whole cardiac cycle, with 2 peaks in this ventricular systole, the second peak during the first phase of diastole, and the lowest velocity is seen during the second phase of diastole, during the atrial contraction. But in normal hearts, there's usually an antegrade flow during the whole cardiac cycle. Most guidelines recommend to see only 2 pulmonary veins, that are the inferior ones, one coming from the left lung and the other from the right lung. The one coming from the right lung usually goes parallel to the interarterial septum, and the one coming from the left lung usually goes in straight angle with the atrial septum, and with color Doppler, we may see how the flow is entering in the left atrium without any problem. And has this already been said today, the only vascular structure that can be seen in normal situation behind the left atrium is the aorta. Any other vessels seen behind the left atrium must be considered abnormal. And this is an important point. From the epidemiology point of view, these are very uncommon conditions, only 7 cases for 100,000 newborns, and represent more or less 1–2% of all cardiac defects in postnatal life. In most cases present in isolation, but in 1/3 of the cases can be associated with other heart defects. The risk of chromosomal abnormalities is low, but the risk of non-chromosomal syndrome is high, mainly heterotaxis syndromes, but also Bacterl, Frinz, Catide, and other syndromes. The prognosis is usually very good, especially if isolated, especially if we do the diagnosis prenatally, especially in those that are obstructed, and we will see these cases later on. In these cases, when the abnormal pulmonary venous return is isolated and the diagnosis is made prenatally, the mortality CTOA is around below 10%. However, The abnormalities in the pulmonary venous return has the lowest prenatal detection rate among all congenital heart defects, below 20% in all series that have been published to date. But this prenatal diagnosis may be life-saving for some babies, especially those that have an obstructed type of pulmonary venous return. And that's why it's very important to put the focus of this lecture in a meeting like this to remember the importance of the detection of this condition. There are not so common that others that we have talked today, but they are very important to make the diagnosis prenatally. And there are mainly two types of abnormal pulmonary venous return. Totally abnormal, where all pulmonary veins drain in another side different to the left atrium, or partial, where 1, 2, or 3 pulmonary veins not drain in the left atrium. Starting with the first type, the totally abnormal pulmonary venous return, there are 4 types of totally abnormal pulmonary venous return: supracardiac, cardiac, infracardiac, and mixed cases. In the supracardiac type, which is the most common type of totally abnormal pulmonary venous return, the pulmonary veins enter in a collector that runs up through the vertical vein to connect with the innominate vein and then connect to the superior vena cava and the right atrium. This is by far the most common type. 50% of the cases of totally abnormal pulmonary venous return are of this type, the supracardiac type. 25% of the cases are cardiac, where the pulmonary veins, there is a confluence vein that receives the flow of the 4 pulmonary veins, and this collector connects with the coronary sinus. This is the type 2A, and the type 2B is where the pulmonary veins enter directly in the right atrium. And in another 20% of the cases, we have the infracardiac type, where it's a vertical vein that receives the flow of the 4 pulmonary veins, then goes down to the abdomen, usually drains in the portal vein or in the ductus venosus or even in the inferior vena cava. This is a long vertical vein that crosses the diaphragm. This usually is the type that is more often obstructed, and this is the type that is more important to make the diagnosis prenatally because of this characteristic of obstruction. And only 5% of the cases are mixed. There are different combinations of the above. Let me show you some examples of these types of totally abnormal pulmonary venous return. In type 1, when there is a supracardiac type, there are some clues that make it easier to have the diagnosis made prenatally. The first point that we have usually cardiac asymmetry with the right side larger than the left side due to the volume overload that we have in the right side, but it is usually a late sign that only is seen in the second half of pregnancy. It is more important to see that there is an absence of venous connection to the left atrium, and the posterior walls had a smooth appearance because there is no vein entering in the left atrium. And moreover, we can see abnormal vessels behind the left atria, and there is the venous confluence chamber and the visualization of the vertical vein connecting with the innominate vein. And moreover, there is an enlarged innominate vein that connects with the superior vena cava, and we can see also this with color Doppler. And it would be important, we see later on the differential diagnosis with persistent left superior vena cava. This is one example of this supracardiac totally abnormal pulmonary venous return. We have vessels here behind the left atrium. We see the smooth appearance of the left atrium wall, and we may see here a vessel coming from the right to the left. This is in blue color. This is the collector coming from the right side of the thorax to the left side. That is behind the left atrium. This is completely abnormal. There is no, this is with continuous flow. This is the pulmonary arteries, the pulmonary branches, and you have to follow these vessels to see where it finished. And you will see now that there is an additional vessels here at the left of the pulmonary artery This is the vertical vein. You can see now that we have 4 vessels. This is the right superior vena cava, the aorta, the pulmonary, and here the vertical vein. There are 4 vessels in the mediastinum of this baby. And one can think, firstly, that this is a persistent left superior vena cava. But in these cases, when there is a persistent left superior vena cava, usually the innominate vein is absent. But in this case, on the contrary, we have an enlarged innominate vein connecting the vertical vein with the right superior vena cava. And this is a very powerful marker to make the differential diagnosis between persistent left superior vena cava and totally abnormal pulmonary venous return. So you have here the collector that receives the blood flow of the 4 pulmonary veins. Here is the vertical vein, then connects with the innominate vein. We have here the innominate vein, very enlarged, directing the blood flow to the superior vena cava. Another example, many times we see these abnormalities in the context of heterotaxis syndromes, cardiosplenic syndromes. We may see here these abnormal vessels crossing the thorax of the baby behind the left atrium. There is no pulmonary vein entering the left atrium. You may see here this vessel coming from the right to the left side, coming from the left to the right side, and with a pulsatile blood flow in it. And we have to see where it connects, and we will see that it is connecting with the superior vena cava. Here it is around the superior vena cava and then to the right atrium. Another example, also in cardiosplenic syndrome, this is the gastric chamber in the right side. This is the aorta. This is the heart in the left side with AVSD. Quite similar to the ones that Ravi showed us just before. We double outlet of the right ventricle with a huge aorta and a small pulmonary artery. But these are the pulmonary branches that are very small, filling from the arterial duct. But let's see these abnormal vessels behind the left atrium. You may see here, crossing in a transverse plane from the left to the right. And we are going to see now where it drains. And with color Doppler, we may see that the pulmonary veins of the right lung are going to the athicus vein here. We see here the pulmonary veins and the collector coming from the left side are going as well to connect with the collector from the right side, from the left side. So this is type 1 supracardiac examples of totally abnormal pulmonary venous return. In type 2, there is a cardiac connection, either in the coronary sinus or directly in the right atrium. Once again, there is absence of venous connection to the left atrium. There is a smooth appearance of the left atrium wall. There is an enlarged coronary sinus. There are abnormal vessels draining into the right atrium, and we may show you some examples. You have here a 4-chamber view with a right heart dominance. There is an abnormal appearance of the connection of the pulmonary veins with the left atrium. And in another plane, we may see that they are connected with the coronary sinus. They are not draining separately in the left atrium. This is the connection of the 4 pulmonary veins into the coronary sinus, and then going to the right atria. Another examples also in cardiosplenic syndrome. This is the right side of the heart, this is the left side of the heart, and we may see here the pulmonary veins entering in the right atrium. We will see nicely now with color Doppler. I said you before that many times we make this diagnosis in the context of babies that have additional problems, mostly in the heart. It has here that the pulmonary veins are draining into the right atrium, or at least in the right part of the common atrium of this baby with ABSD. And another example in a baby that has an absent left lung and hypoplastic right lung, and only see the veins of the right lung draining in the left side, in the left atrium, in the right atrium, excuse me, in a baby with another problems. And the type 3 is the infracardiac type, where it's a vertical vein, a long vertical vein, a long and narrow vertical vein that goes down to the abdomen and usually connects with the portal vein. Once again, there is smooth appearance of the left atrial wall, and we may see here, this is an example, you see the upper abdomen. There is an enlarged vessel here in the upper abdomen. This is the gastric chamber. And we move to the thorax, and we see these vessels behind the left atrium that receives some vessels from one lung and from the other. This is the aorta, and you see this collector receiving. We will put now the color Doppler to see that these are vessels and not another structure. In the context of a normal, usually apparently normal heart with only the right side larger than the left side. This is the pulmonary artery, pulmonary valve. The aorta is smaller than the pulmonary artery, but back to the abnormal pulmonary venous return, we may see here that this actually receiving the pulmonary, the blood flow from the pulmonary veins, and this vessel, when we move the transducer and made a sagittal plane, we may see that this vessel is crossing the diaphragm and going down to the fetal abdomen and draining in the portal vein, and that's why this portal vein is so enlarged. So, as an example of type 3 totally abnormal pulmonary venous return, here this is the portal vein. Another example of this condition, you may see here in the upper abdomen 3 vessels, the aorta, the inferior vena cava, and another vessel that you don't know what it is. We see 3 vessels here in the upper abdomen, and we have to follow this vessel, that is the vessel that is an additional one, that is in the left side. If we move to the thorax, we see the vessels as well. Here, between the left atrium and the aorta, there is an additional vessel. This is not the esophagus, as we will see later, because it receives blood flow. And we rotate the transducer and make a sagittal plane. We may see this. This is a vascular structure going down to the abdomen. Yes. And going down from the thorax to the abdomen in color in blue. And we move down, we move up again to the thorax to see this vessel, and is located behind the left atria and receives the flow of the 4 pulmonary veins. This is the additional vessels, and this is the vertical vein receiving the blood flow from the pulmonary veins. So this is another example of type 3 totally abnormal pulmonary venous return. There is no vein entering in the left atrium, as you can see nicely in this video clip. This is our example of totally abnormal pulmonary venous return. We have also the partially abnormal pulmonary venous return. Again, there are 4 types. In the first 2, the anomalous right pulmonary veins connect either with the superior vena cava or the inferior vena cava. This type usually is associated with hypoplasia of the right lung, which is called the excimitar syndrome. I will show you later one example. And in type 3 and type 4 are the pulmonary veins that are draining abnormally and connect either with the left innominate vein or directly with the right atria. There are 4 types of partially abnormal pulmonary venous return. One example of excimitar syndrome, there is a vertical vein that has a shape of Turkish sword, which is scimitar, that receives, that goes down to the abdomen and drains usually with the inferior vena cava or the vena porta. And usually there is an hypoplasia of the right lung. Usually it goes with dextrocardia or mesocardia, and there is absence of connection with the right pulmonary veins and the left atrium. One example, you may see here that the heart is located mainly in the right side because the right lung is very small. Sometimes it's associated with sequestration of the left lung, but most commonly with hypoplasia of the right lung. There is no pulmonary veins from the right side connecting with the left atria, and we have to look for where they are, and they more often are connecting, crossing the diaphragm and connecting with some abdominal veins, usually the inferior vena cava. The heart looks as enlarged because there is less space occupied by the fetal lung, and that's why the heart appears as larger than normal. There is no pulmonary veins. This is the left pulmonary veins draining normally, but there is no pulmonary veins coming from the right side to connect with the left atrium. But we will see later on that how they are crossing the diaphragm and connecting with the abdominal veins. Yeah, this is a small, very small pulmonary artery on the right side because the lung is also very small. This is the pulmonary artery. Yeah, this is the left pulmonary, the pulmonary veins connecting normally with the left atrium, and these are the pulmonary veins of the right side crossing the diaphragm and connecting with abdominal veins. Another example, you may see this baby that have a very well-known heart defect. That is with a normal four-chamber view, and this baby has, you may see, a transposition of the great arteries with the pulmonary artery connected with the left ventricle and the aorta connected with the right ventricle. This is a simple type, apparently a simple type of transposition of the great arteries, but you know which is the most difficult cardiac defect to diagnose? Which is the most difficult one? The second one, because more often when you see one defect, you don't think that there can be another defect associated. And if you see this baby, you may see that only the veins from the left side, from the left lung, are connected to the left atrium. But there are no right pulmonary veins connected with the left atria. So we have to look for these veins. Only the left ones are connected with the left atria, and we must look for where are the other, the ones from the right side. And a baby that usually have a simple transposition of the great arteries, there is no associated defect. You may see here the pulmonary veins of the left side. However, the pulmonary veins from the right side, also cross the diaphragm and connected with the inferior vena cava in this baby. So always think that whenever you make a diagnosis of any congenital heart defect, they may be associated defect. This is the normal pulmonary venous return in this baby. Another example, in this case of type 3, you may see a normal heart, apparently normal heart. But it's very easy to overlook this defect because you see an almost completely normal heart, but if you put the focus here, you only see the veins coming from the right side connected with the left atrium. However, the veins from the left side are not entering in the left atrium. This is very easily overlooked prenatally, and you have to follow to see. There are here the veins. If you put the color Doppler, it's obviously more easily recognize that these veins are coming from the left to the right side to connect with the superior vena cava. So This is a very difficult diagnosis, but if we were able to make it, this diagnosis due to. This, and the rarest form of abnormal pulmonary venous return is the called cor triatriatum or triatrial heart, where the cardiac usually there can be sinister or dexter. It's more often sinister on the left side then. And the most common type, the left atrium is divided in two chambers, the proximal chamber that connects the pulmonary veins with the pulmonary veins, and the distal chamber that connects with the mitral valve. And these chambers are connected by the membrane that usually have a defect that allows that the blood flow comes from the proximal chamber to the distal chamber. This can be also diagnosed prenatally. You can hear an example of how this left atrium is divided in two chambers. This is the distal one connected with the mitral valve, the proximal one receiving the pulmonary veins. Okay? This is a very uncommon condition, the cor triatriatum, but at least you know that this condition exists. I just finishing my presentation. Differential diagnosis must be made called odd condition that implies cardiac asymmetry with the right side larger than the left side, especially coarctation of the aorta, which is by far the most common cause of cardiac disproportion. In these cases, we may see the pulmonary veins entering in the left atrium, and therefore it's very easy to distinguish between coarctation of aorta and totally abnormal pulmonary venous return. And with another causes of seeing four vessels in the mediastinum, and especially with the persistent left superior vena cava. When we have a persistent left superior vena cava, we have four vessels in the mediastinum, but usually there is an absence of innominate vein. However, when we have a totally abnormal pulmonary venous return, as I showed you before, there are also four vessels, but there is an enlarged pulmonary innominate vein. So it's very easy to make the distinction between these entities. And of course, we don't see any pulmonary vein entering the left atrium in this last case. Which is the clinical repercussion of this condition can vary very much from to be completely asymptomatic to be critically ill, this baby, depending on several factors. One of the most important is the obstruction of the pulmonary venous return. There is no consensus on how to define the pulmonary vein obstruction. There are several patterns associated with this obstruction of the pulmonary, of this vertical vein. You must suspect it especially in the infracardiac type, pulsatile with low profile or turbulent flow in the pulmonary. So there is no consensus, and therefore all these babies should be born or should be delivered in tertiary care referral center with cardiac surgeons close to the delivery room in case that these babies become critically ill after birth. From the prognosis point of view, we have there is this paper from a Canadian group with almost 140 cases of totally abnormal pulmonary venous return, only 10% of the cases diagnosed prenatally, and the most single parameter to predict the prognosis is the presence of cardiosplenic syndrome. Neither of these parameters have an impact, a clear impact in the prognosis. Just to conclude, this baby should be followed up to 4 weeks. They be delivered in tertiary care referral center, and they may need surgery that usually performed in the first 2 months of life in the totally abnormal pulmonary venous return, and sometimes even in the first hours after birth, if obstructed. And in cases of partially abnormal, the surgery can be delayed in order to reduce operative risk to a minimum. And once again, using the data of this database, you may see for isolated cases, the mortality is very low, even lower for partially abnormal, but also very low in cases of totally abnormal pulmonary venous return. Just to conclude, please don't forget ever to look at the pulmonary veins. Don't forget that they exist as the aorta of the pulmonary artery. The pulmonary veins also exist, and they have to be assessed whenever a prenatal scan is made. Most cases of abnormal pulmonary venous return presents in isolation, and this implies a more challenging diagnosis. The aorta is the only vascular structure that can be seen behind the left atrium. Additional vessels are always abnormal. The smooth appearance of the left atria is always abnormal. The confluence of pulmonary veins in a single vessel close to the left atria on the right, close to the left atria or the right atria may lead to suspect totally abnormal pulmonary venous return. This condition is one of the diagnostic possibility whenever cardiac disproportion is detected, with the right side larger than the left. Totally abnormal pulmonary venous return and the partially abnormal type 3 are among the diagnostic possibilities whenever 4 vessels are seen in the 3-vessel trachea view. The most common is the persistent left superior vena cava, but this is not the only one. Additional vessels in the upper fetal abdomen may lead to suspect totally abnormal pulmonary venous return, especially type 3. And finally, cor triatrial heart or cor triatriatum is a rare but easy to detect prenatally condition because the left atria is divided in 2 chambers, with the proximal one receiving the pulmonary veins. I thank you so much once again for your attention.